So move right along. I won't spend too much time here because you guys should understand this since we've talked about it already, and this is a difference between shunting and dead space. And shunting and dead space are both examples of what's known as ventilation perfusion mismatch, or VQ mismatching. So these are both examples of a VQ mismatch. And remember, we talked about the ventilation in the lungs should more or less match the perfusion, right? Not quite, but about 80%, right? So ventilation approximately equal to perfusion, all right? And a mismatch, okay, means what? That you have more ventilation and less perfusion, or more perfusion and less ventilation, right? Those are the two general types of mismatches we get. And this leads to the concepts of shunting and dead space. So let's just review what those are again. So shunting means that we have what? Normal perfusion of the lungs, right? So blood's going through the lungs, but the lungs are not being ventilated. So what does that mean? That means that the blood can flow through the alveoli, but there will be no gas exchange, right? So the blood basically goes from the right side of the heart to the left side of the heart without being oxygenated. That's the best way of looking at shunting. What are some things that can cause shunting? Pulmonary edema, right? Might be one if your alveoli are full of fluid, like ARDS we talked about earlier. If you have a pneumonia, right, and you have lots of consolidated matter in the alveoli, or if you have a pulmonary contusion. What's pulmonary contusion? So bruising. Generally, it's traumatic, right? And so that would be blood and swelling within the alveoli. So you can still have perfusion, but the low ventilation will prevent oxygenation of that blood. Okay, that's shunting. However, dead space is normal ventilation but low perfusion. So I can get gas in and out of the alveoli, but I can't perfuse the alveoli. And what's the classic thing that we run into here? The classic cause of dead space? Well, pulmonary embolism is the classic thing that's easy to understand, right? You get a large pulmonary embolism that prevents perfusion through the lungs, but you can still ventilate the lungs, and that's why people with significant pulmonary emboli or embolisms, that's why when you give them oxygen, they don't necessarily improve. Why? Well, because there isn't perfusion through those well-oxygenated alveoli. And we also know that the ventilator circuit and airway equipment can also cause dead space as well, right? And we talked about anatomical dead space, and this is the normal dead space that we find in a healthy person, right? Basically, that's the air in the conducting airways that is not participating in ventilation, or rather respiration and gas exchange. What's the formula for that? It's the formula, right? Because we need to know that to calculate alveolar minute ventilation. Yep. So you take their pounds. There you go. 1 milliliter per pound, right? 1 milliliter per pound in a healthy person, right? And that's why we say in your average, it's right up there too. Your average healthy adult patient, 70 kilogram, generic 70 kilogram adult male, is about 150 milliliters. Why? Because it's about 150 pounds, right? Okay. You also have other types of dead space. You can have physiological dead space. And physiological dead space is due to perfusion pathology, right? So physiological dead space is due to some problem like a pulmonary embolism. And then mechanical dead space is dead space that we can add, i.e. you add a ventilator circuit, and you put a bunch of HMEs in there and some HEPA filters perhaps, and then you add some more circuit because you want to do an inline neb, right? And so you have all this tubing that takes up dead space. That can also add dead space to your patient. And this is mechanical dead space is particularly important when we talk about pediatric patients, right? So, you guys okay with that? Yeah. Right? So anatomical is normal, what we expect in the conducting airways. Physiological dead space is due to pathology. And then mechanical dead space is due to the equipment, mainly, that we know. Okie dokie. You guys good with that? All right, moving right along. Okay, so here are some additional tests, and we've gone over these formulas already, but let's just go ahead and make sure that we are good to go here. See if I can. Okay, so you guys remember the PF ratio, right? How do I calculate the PF ratio?
PaO2 over FiO2.
Good. So the PaO2 divided by the FiO2, right? And basically what this tells us is this is the FiO2 needed for a given PaO2, right? And I'll just give you an example of a normal patient. So normally your PaO2 is right around 100 on room air. So 100 divided by 0.21, and that gives us about 476, right? Which is basically normal, right? The normal PF ratio is around 500. All right. We know that a low PF ratio, less than 300, indicates that there's a possibility of ARDS or a lung injury, right? Okay. If the PF ratio is less than 200, that's a moderate lung injury or ARDS. And then obviously if it's less than about 1 or 200, that's a severe situation, right? That's somebody who's on 100% oxygen and they have a PaO2 of like 70, right? That indicates there's a severe problem there. And the PF ratio reflects, it gives us a reflection of the A to A gradient. And you guys remember that, right? We had to slog through the alveolar air equation to calculate the P big AO2 pressure in the alveoli. Once we figured that out, we subtracted from that the P little AO2, right? And that gives us the A to A gradient. We know that the larger that number is, the more difficult or the more problematic it is. It's a reflection of there's more difficulty in getting that oxygen from the alveoli into the blood. So you would imagine, right, someone with ARDS, for example, would have a very large A to A gradient, right? Or someone with pneumonia or cardiogenic pulmonary edema or something like that. Their A to A gradients would get larger. You guys good with that? Okay. Remember we talked about dead space? There is actually an equation for calculating dead space. I'm not going to make you guys memorize it, however. I'm just going to cover it. That way you're aware of it. But it's nothing that you're going to come up against on an exam. Unless you want to go to respiratory school, then there are so many equations you have to memorize. It's ridiculous. But the dead space equation, sometimes it's known as a Bohr dead space equation, is also known as the VDVT, right? The volume of dead space over the tidal volume. And the way that we measure this is PACO, PACO, PACO. That's how I remember it. PACO, PACO, PACO. So you take the PaCO2, you subtract from that the PET CO2, that's the end tidal CO2. The PET CO2, that's the end tidal CO2, right? So you got to know their end tidal CO2, and then you got to know their PaCO2, and then you divide that number by the PaCO2. So let me give you an example. Let's say that our patient has a PaCO2 of 40, and they have an end-tidal CO2 of 35, right? So I take 40 and I subtract 35 from it, and that gives me what? That gives me 5. And then I divide that 5 by 40, right? By the PaCO2, and that gives me 0.125. Okay, and then if I convert that to percentage, that would be 12.5%. And so what that tells you is 12.5%, okay, 12.5% of what they're breathing is dead space. Does that kind of make sense? And in patients that have dead space pathology, you would expect that percentage to increase, right? And in some cases, we might even allow up to like 50-60% dead space in someone who's on a ventilator, because we understand that the ventilator equipment and the circuit and all that's going to add a significant amount of dead space. But if you had a patient that you had just intubated and you're bagging them and you get an ABG on them and you have a dead space of 60%, that's rather problematic, isn't it? That is rather problematic, that you need to investigate what's going on. So normally we're looking at 28 to 33%, okay? And again, like I said, that will often get higher in an intubated patient due to the mechanical dead space that we're adding. Okay, assessing for hypoxemia. You guys remember this, right? The good old CaO2, the content of arterial oxygen. And that's just the hemoglobin in grams per deciliter multiplied by 1.34 multiplied by the saturation. And why do we have the constant 1.34 in there? What's significant about that? Why is that in there? With math, it's really easy to go, oh, it's just a constant we throw in there to make everything work out. But I find if I know the reason why there's a constant, I understand the formula better. No, actually not. Remember, the left-hand side of this equation is oxygen bound to hemoglobin, right? This left-hand side is oxygen bound to hemoglobin. The right-hand side is dissolved. Not quite. But maybe moving in the right direction a little bit. So what this means is 1 gram. If I had 1 gram of hemoglobin, 1 gram of fully saturated hemoglobin will dissolve 1 vol% of oxygen, right? Does that make sense? So if I had a hemoglobin of 1 and a saturation of 100%, right? So 1 gram of hemoglobin per deciliter, right? And a saturation of 100%, so that 1 gram of hemoglobin is fully saturated, I would have 1.34 milliliters of oxygen. Now, if a patient had a hemoglobin of 1, they would not be living. But that's just an easy, for the math. Does that make sense why that constant's there? Right? And that's why the saturation's there, right? So if the saturation's 70% and their hemoglobin's 10, well, that means 70% of that 10 grams per deciliter hemoglobin saturated, right? That's 70% of the 1.34 per gram, all right? So we figure out how much hemoglobin we have, how much oxygen we have bound to hemoglobin, and then we add to it over here, right? And this is the oxygen that's dissolved in our blood. And we know that oxygen is a very nonpolar molecule, doesn't like to dissolve in our blood. And so it's a much, much smaller number. And that is 0.0031 multiplied by the PaO2. And where did I get this constant here? Well, this constant basically says for every millimeter of mercury of oxygen that I have dissolved in my blood, I will have 0.0031 milliliters per deciliter of oxygen, right? So significantly smaller. Can you guys envision or imagine in a situation, however, where this side of the equation is going to be a lot more important? Is there a situation, a therapeutic situation, where we could substantially alter the right side of the equation to increase arterial oxygen content? What would CPAP or intubation do?
Increase the pressure.
Okay, so let's say that I put them on 100% oxygen. That might work, right? So what would be, so let's say that I put them on 100% oxygen, CPAP, or they're intubated at sea level. What would be the maximum amount of oxygen that I could have in theory? What would be my maximum PaO2? Yeah, okay, let's just go hyper ideal,
So
right?
hyperbaric chambers.
Oh man, you stole my thunder from me. Yeah, right. If you put somebody into a hyperbaric chamber, right, and let's say I put them under 3 atmospheres in a hyperbaric chamber, right? Well, what's 760 times 3? Times 3. It's gonna be a little more than 420, huh? 2280. 2,280 millimeters of mercury. What, now multiply that by 0.003. Yeah, 2280 multiplied by 0.003. That gives me 6.84 vol percent. That's actually pretty substantial, right? I mean, it's still not as high as over here, right? But that's pretty substantial. And if I have a problem, maybe my hemoglobin is poisoned by carbon monoxide, right? So I can't fully saturate the hemoglobin. Maybe I can only saturate 50% of the hemoglobin, right? I could make up for some of that by putting that patient in a hyperbaric chamber and increasing the amount of oxygen they have in their blood through pressure, right? And then, of course, we know that high pressures of oxygen decreases the amount of time that carbon monoxide is bound to hemoglobin. So, yeah.
Push the projector to because it's still on your chair. Thank you.
How's that?
Perfect.
Better? Perfect. Why didn't someone say that earlier?
I did.
Huh? Well, you didn't tell me to push the
It was
projector.
your chair, and you're like, okay, and you turn it back again. Never mind. I didn't want that note in here.
Yeah, there you go. You didn't need that anyway. Is that better?
Yeah.
All right, cool. Yeah. All right, good deal. So, yeah, hyperbaric chambers can actually make a difference, and this is why sometimes they're used for wound healing. Actually, that's the primary use for hyperbaric medicine is wound healing. When I did a hyperbaric rotation in respiratory school, and we didn't see a single dive injury. The whole week I was there, it was all wound injury. Yeah, diabetics mainly, diabetics. Yeah, I think 16 people at a time we put in it's a big multi-place, it's called a multi. Basically, I have 2 types of hyperbaric chambers. You have a monoplace chamber, which just fits one person. And then you have a multi-place chamber where you can fit multiple people, and you have providers inside as well. Yeah. Oh yeah, it's the chamber that I was working with was about the size of this room. This is in El Paso, actually. Yeah. This is in El Paso. Yeah.
That's pretty much the only.
The
hyperbaric
only
chamber
one
we've
in
got
this
the area.
in this region. The only multi-place that we have in this area. Yeah.
Although they have in Albuquerque.
I don't know. They probably have a multi-place up in Albuquerque.
Mountain View has one.
A multi-place?
Not a multi.
Yeah, it's a mono place.
Time when we needed
Yeah.
it, we have it, December press out there.
We sent 2 out 8 people.
Yeah, they can't handle that.
Yeah, and it's mainly for wound, not for carbon monoxide toxicity or dive injuries. You know. So El Paso would be the closest one that they could do.
Dive injuries would be a little bit more common. I've gotten pretty close to
Yeah.
doing it to myself,
Oh.
just not paying attention.
We don't see them, or at least they didn't. I talked to them about it. They're like, oh, we rarely see dive injuries. Well, and some of it's just people don't dive here. Like,
There's not deep enough.
yeah, if you know in Florida,
Hole's pretty much the only.
yeah, Florida, California, you live in a coastal area with relatively warm waters, you actually see a lot more dive injuries than here in New Mexico, where people diving in the Las Cruces area. Yeah, T or C if you can see.
That 3 feet of water we've got in the Rio.
Yeah, yeah. I mean, you've got the lake, but that's
96 feet or
the
something.
visibility is not great.
Yeah.
You know, and who wants to immerse their body in the Rio Grande anyway, right? I don't. Yeah, I know. Okay, so there we go. Okay, let's cut it off there.